This conference will now be recorded. This
Basically,
conference will now be
if you have
recorded.
to set up a critical care unit, first of all, you need to see that what type of people you are serving in that area. Okay? Um, because the unit has to be a viable one, and like it should be cost effective. So then, where is the next critical care unit? Is it close to your existing facility or it is far and away? So that is one thing. Then the rest of the things you have mentioned that we should do a ground survey. First survey should be there. How many patients are you dealing with? Are you dealing with only OB-GYN care, or you are dealing with other, or your hospital is providing care for other disciplines also? Then how many people are coming to you and what percentage is going to critical care unit? So first of all, you will have to see that is it really essential? How much it is going to cost? And how you
Okay.
can start the service. Do you have the funds? Then, whenever you are running any facility, you need several things like do you have qualified people? If you have qualified persons, trained persons to run the setup, yes, that is one thing. Then, is it the right place? You have expertise is one thing. Then, do you have the this all equipments? And then
Okay.
you really provide care, and then can you sustain it in the long run, or you can't. So then after that, you said that how many people are coming, how many beds should be there, and what should be the staff. Like you need an anesthetist, you need
Yeah.
critical care consultant, physician, and then you need the uh, rest of that. They will be the head of the critical care unit,
Okay.
and and because neonatologist, they will have their own neonatal care unit, intensive care unit. Okay, so we're concerned about our critical care unit. How many beds should be there? Then after that you can do that. Then
Okay.
you should be able to provide level 2 care, and then you will have to do the audit also. That do you have an enough number of patients
Okay.
going on vent with cardiothoracic monitors. All of these things you have to mention, and then that
Okay.
would run it in the long run. Okay, and
Okay.
then you
Okay.
can say that after that you will expand. That it should be close to it should be on second floor. It should be close to the ICU. It should be
Okay.
close to the theater, and have uh, trained staff in the morning, and then someone should be on call, and then we need to run the workshops to train our critical care team. All of these things
True.
should be there. So if you are
Okay.
going to touch these headings, you are going to be fine.
Okay.
That is
Okay.
one.
Okay. That's fine.
This conference will now be recorded.
Mm. Instruments are simple, so you don't have to struggle with them. So, do you have an opportunity to go over the abortion laws?
Yeah, I have gone through. It's the same like the RCOG law, no, doctor? Like
Yeah.
1, 2, 3, A, B, C, D, E, F, G. The A1 is uh, grave injury to the life of the mother. Then second one is the physical and the mental health. Seriously affecting the physical and the mental health. Third one is less than 24 weeks, affecting the physical and the mental health of the mother. Fourth is threat to the existing children. Fifth
Yeah.
is if the child is born with severe handicapped or so. Those are the guidelines, right? Those are the
Yeah.
things.
Yeah,
Yeah.
these are the guidelines and
Abortion Act.
of the Abortion Act. And now, they are telling here also that we can offer them on the same grounds.
Okay.
So nothing is going to be different.
Okay.
So if you get a baby
Mm.
with some congenital anomalies, you will take 2 minutes, then we'll talk about her. If you get a
Okay.
baby like mother has been diagnosed with omphalocele, so what will you like to tell her? You will take two
Uh,
minutes. and how you will counsel her, how you will break the bad news, and
Uh-huh.
what should be done next. Okay, you should
Okay.
take 2 minutes, and then we'll talk.
Mm. Okay. Mm-hmm. Okay. Uh, like just wanted to know this abortion act, maybe they will give an anomaly, like in like how Dr. Faridas, someone mentioned that anencephaly or certain things like this. Yes, they fall into the category, yeah, I think the ABCDE1, that threat, if baby is born, it's handicapped or
Yeah,
severely, it
yeah,
will die. So this falls into it. We need to sign the form and the things and explain, break the bad news, as you said. Yeah, the break the bad
yeah,
news and then give
yeah.
the.
So still
Oh,
take 2 minutes, and then
mm,
tell me about that.
mm-hmm.
Okay, because your answer should be in a good order.
Okay.
This
How you are
conference
going
will
to
now be
confirm the
recorded.
how you will
Okay.
confirm the date of pregnancy by her first day of the last menstrual period, or you
Mm,
can do this dating scan
dating scan.
like that. Okay, to
Okay.
like at
Okay.
what time she was booked
uh,
at that.
Okay.
Ideally,
That's
should be less than 12 weeks. So
yeah.
then very important that patient has asked that she doesn't want to have this baby because there are certain problems. So you will have to offer pre-termination of pregnancy counseling.
Mm-hmm.
As
Okay.
you know that multidisciplinary team has to take some action,
Mm-hmm.
and they will advise on care plan, and they will
Mm-hmm.
tell you that what should be the that when you should do it immediately or
Mm-hmm.
later. And counseling will continue.
Okay.
So you should discuss that risks to the life or serious risk to the health. They should take
Mm-hmm.
place prior to termination of pregnancy. So you need to
Pregnancy.
understand what are the risks for her and what are the risks
Mm-hmm.
for her own life. And
Okay.
counseling according to the clinical scenario.
Okay.
So like you will have to explain that what is the process of termination of pregnancy, either medical or surgical, because we cannot offer.
Okay.
Just remember that it is different from the management of miscarriage. That here we cannot offer expectant management.
Yeah.
So,
Either medical or surgical.
either medical or surgical.
Surgical.
And so counseling would also include the risk of continuing the pregnancy and risks of termination of pregnancy, taking account for her of her medical disorder. If
Okay.
she will continue to have this pregnancy, what will happen to her?
Mm.
And if she will like to abort, then what will happen? So you are going to talk about both aspects of the care. So
Okay.
you don't have to talk about uh, all surgical procedures or stuff. You have to tell her
Mm-hmm.
would be likely to experience.
Okay.
She will like cramps, pain, and bleeding, and
Mm.
how long the process is likely to take.
Okay.
What pain management options are available to her? What are the
Mm.
risks and complications associated with the termination method?
Mm.
When she will be
Okay.
able to resume her normal activities, including sexual
Mm.
intercourse, follow-up care.
Okay.
Then
Like
certain
in this
patients,
case,
yeah,
yeah. In this case, like I would like to tell Erin, like in case she wants to opt for a medical termination, first we'll give you a tablet, and after 48 hours, we call you back, and that is mifepristone 200. 48 hours later, misoprostol 800, either oral, buccal, or vaginal,
yeah,
and after that, we'll wait for the spa. This year, you can have a cramp-like pain, but we make sure that we give you a good analgesia, and it will be like a menstrual pain. And in case bleeding becomes heavy or you tend to fall in the blood pressure, we may have to stop the medical line and go ahead with the surgical line of management, a surgical line of termination.
yes,
And
that's true.
uh, and if it is Rh negative, we like to give you anti-D.
Yes,
And
these are very important patient safety points.
mm, mm,
So in case they give you someone who is having some who is considered for termination of pregnancy because she has some medical disorder. So in that case,
mm,
you should tell that if she chooses to continue with her pregnancy, then what
mm,
complications she is going to have.
mm-hmm.
So you should say that. Then if she wants to keep that baby, we'll continue providing care by the multidisciplinary team.
T. Okay.
Then post-op counseling is also very important.
Mm-hmm.
So they can have they can have depression, and they
Mm.
can have like yeah, psychological aspect. So we need to offer
Psychological.
daily med
Mm,
care where
mm.
appropriate, and then they should be given contact number. Always give hospital contact number,
24 hours. Yeah.
24 hours, and for the counseling service for the sport group.
Okay.
So we should also be aware of the serious outcomes like risk of poorer mental health outcomes, and we, in such
Mm,
cases, arrange follow-up to enable early detection of those women in need of
mm.
additional support. That is
Okay.
important. So ask about the social support system also. Then
Okay.
then you need to offer her contraception also, because you are
Mm,
offering this termination of pregnancy due to some important thing, right? So it
yeah.
says
So, yeah.
that WHO also recommends that for such patients who are coming for termination of pregnancy because of their condition, then you should give them appropriate contraception, like you can before they leave the premises of the hospital. Okay, and if they don't want, if
Okay.
they want to, if they have some special problems like thrombophilias or
Mm,
history of cancers
mm,
or some disease is very serious,
mm.
then you will refer them to the specialist. Don't advise anything for them yourself. Okay, refer them to the
Okay. Okay.
specialist. That is one
Specialist.
safety point. So these are the things that you should be offering them. Okay.
Yeah.
So about the drugs, they will now we know that we can offer them simple,
Yeah. Medical term. Yeah.
yeah, medical. So you think that you should be offering them mifepristone?
Yeah. And now the reason they say that you can give it to them at home.
Yeah, you can get if the patient meets the
Mm,
criteria, all is
yeah.
tightly closed, we can give
Yeah.
them, and then after that they can go home. Then another important point will be you should say that you know that that society is much more religious than other places, right? People are
Yeah.
like religious, they're concerned, so what you can say, and you should give her appropriate analgesia also. Okay?
Mm-hmm.
So in a conservative orthodox society, you
Mm-hmm.
need to say that
Yeah.
you will respect the tissue, baby
Mm-hmm.
remains of the tissue with respect, and what
Mm-hmm.
she will like to have. She will like to have a burial, or she will like the hospital staff to dispose that, because the disposal of the fetal tissue is also very important. Okay? That is important.
Okay. Okay.
So if if you have like, they will ask you about the methods also. Okay?
Mm.
Expectant, we have no chance.
Okay.
So we will get a special pack. That is their
Mm.
plan. They can have they can get like 800 micrograms of misoprostol, and
Yeah.
the process, it will involve like you can give mifepristone, because if the os is tightly closed, then you are going to give them mifepristone. What type of drug is mifepristone?
Or pardon? Antiprogesterones, mifepristone.
Anti-progesterone, which is selective
Yeah.
progesterone receptor modulator. You will give that one, give them, after call them back between 24 to 48 hours, and give them 800
Uh,
micrograms of misoprostol. Any route can be used, but
prostaglandin
vaginal route
even.
is
Yeah.
better. But if she has, because she will have no bleeding, so you can give her vaginally also. That
Mm.
the with the buccal and the sublingual action will be quick, but for miscarriage, you need a sustained level of the dose of the drug in the
Yeah.
system. Okay?
Yeah.
So that is also easy. And then NTD, like you said before, and
Mm.
after that, you need to give a good analgesia. Pain and bleeding, two complaints should never be ignored. Give them
Okay.
ibuprofen. You can give them paracetamol and choline phosphate. Don't have to remember
Mm.
the names of the drugs. You can say that you can give them good
Mm-hmm.
analgesia. Okay.
Okay.
And then whenever you will offer any treatment to any patient,
Mm-hmm.
anytime you talk about some drug, always
Yeah, I
talk
said
about
that's side
what to
effect.
expect,
Mm.
side effects, nausea, vomiting,
Yeah.
diarrhea, and you can
Okay.
get fever or you can get chills.
Yeah.
Then none of the interventions is ever without complications.
Okay.
90% patients, they will go smoothly, but maybe
Mm-hmm.
10% they will develop some problems. So don't ignore that 10% also. So tell
Okay.
her that if you will give her medical treatment,
Mm-hmm.
then it will prevent the chance of having surgical intervention by almost 70%. Okay, that is
Mm-hmm.
the good point. But if
Mm-hmm.
she starts having severe pain or bleeding increases severely, it becomes heavy, she is passing clots, then maybe we will have to go for evacuation of retained products of conception.
Okay.
That is the one. So after
Okay.
that, offer her contraception. If she has
Mm-hmm.
heavy bleeding, she will need this blood transfusion. And
Mm.
if she vomits within 45 minutes after the intake of mifepristone, then its efficacy will decrease. So in that case, you will have to give 200 mifepristone additionally can be given. Then for such patients, don't leave them after this
Mm.
termination of pregnancy. You have to arrange follow-up care. If you
Okay.
can do the urine pregnancy test if she's a low risk woman, so we can do this
Mm.
urine pregnancy test after 3 weeks, and that's fine.
Mm.
But if she has
Mm.
some medical condition, or then she should come back after like 4 weeks, and you have to give contraception at the time of miscarriage.
Okay.
Then method for 9 to 12 weeks, again the same stuff, 200 mg
Mm.
mifepristone, and then you are going to give them
Mm.
after 24 to 48 hours, you are going to admit. You will not give misoprostol and send her home, because, as you know, you must have observed, experienced that patient is going to have severe, this abdominal pain and bleeding. Then provide
Mm-hmm.
good anesthesia in the same way, same side effects. Any duration, you can say that. Complications,
Okay. Fine.
that if it is, if you know the complications will increase as the gestational age will increase. Like now it is now
Mm.
9 to 12 weeks. So you can say that just a minor number, a minority, like 3 out of 1,000, they will have pain and bleeding prior to starting
Mm. Mm.
misoprostol. Okay.
Mm-hmm.
And then prolonged bleeding up to 12 days is common. If she comes back and she has bleeding, so you should do ultrasound. If there are no POCs, then you are going to tell her that it may continue. And I'm minority, like 1.5 to 2.9%. Here the miscarriage has failed and we didn't realize, so the pregnancy can continue. Then vomiting, if it has occurred early within an hour 45 minutes, then you need to report to give her another dose. Then
Okay.
we need to tell them that they can come for follow-up to your own facility or they can go to their GP or community doctor for a after-care visit and to discuss contraception if it was not offered at the same time. Then mifepristone. It is important for you to remember that there are certain contraindications to use of mifepristone. Patient was in chronic adrenal renal failure, hypersensitivity to any of the excipients, and allergy to mifepristone. So you need to ask about the patient allergies. Severe
Mm-hmm.
asthma, and which is uncontrolled by the therapy. Inherited porphyria, you don't have to remember, extremely rare condition, and suspected extrauterine pregnancy, or if she has contraindication to misoprostol. Misoprostol, it should not be used if your patient is hypersensitive to misoprostol or other prostaglandins, or if you are suspecting an ectopic pregnancy. So anyhow, before starting any intervention, you have to be 100% sure that what is the diagnosis of your patient. So if intrauterine pregnancy has been located and she has some problems, then you can offer them. So then on the basis of mifepristone metabolism, um, it is possible that ketoconazole, these are enzyme inducers, they may inhibit
Mm-hmm.
its metabolism, so the serum level of mifepristone will increase. And if he's taking like rifampicin, dexamethasone, St. John's wort, and anticonvulsants like varenicline, phenobarbital, carbamazepam, they may induce mifepristone metabolism, so the dose will have to be increased. Basically, you should just know that your patient is stable. She has no contraindication, doesn't have any abnormality, coagulation profile is normal, and then you are going to deal with them. So regarding surgical methods of termination, so do you think that you can offer this if the patient comes to you at an early stage? So how you can offer surgical termination of pregnancy?
Yeah, the patients who deny the medical termination, yeah, we can go ahead with the surgical termination. Or in conditions like previous anemic or required a blood transfusion or any inherited thrombophilia, as those conditions where you expect the bleeding is high, or patients with Jehovah's Witness or those conditions, we can offer them a surgical evacuation. It is quick and it is easy for according to your time you can do it, and products of conceptus can be seen after the evacuation. And yeah, but there is a certain complications with this. One is mild complications like infection, pain, bleeding, and the serious ones, risk of perforation, because it is a blind procedure, which is about 1 in 1,000, and injury to the cervix. So these are some of the surgical. It can be done in the less than 12 weeks by manual vacuum aspiration or suction evacuation. Um, uh, so these are the two ways less than 12 weeks we do. And
Yeah,
uh,
and you should say that if it is a viva, you should say that surgical termination is usually not offered if the period of gestation is less than 7 weeks because we may miss the
mm,
sac during gestation. Then
okay.
manual vacuum aspiration can be offered. There are certain, what are the benefits? Because you don't need GA. It can be done
Mm,
under cervical box. You are going to
mm,
walk at 4 points, except at 3
okay.
o'clock and 9 o'clock position. You know, that's how you can always
Okay.
tell them that how I'm a safe surgeon. I know what is the please happen to my patient like that. And it has
Okay.
certain paracervical block can be given, and then what else you can do that if you want to offer this MV, you will have to
Yeah.
give pre-op analgesia like ibuprofen or diclofenac sodium, and then it
Mm-hmm.
will be given like 1 hour to 1.5 hours before the procedure, and you will have to give antibiotics. Which antibiotics are usually used? Doxy and
500,
azithromycin,
500 mg azithromycin or doxycycline 200 mg
200 mg
hours prior to the.
on the day of surgery, right? So then pre-op cervical
Yeah. Yeah.
priming, you can give this again 400 micrograms misoprostol can be given 3 to 4 hours prior to the procedure. Then a cervical block is sometimes administered, and Tonox should be available on request. You don't have to remember each and everything, just give them pre-op anesthesia because you have to stay relaxed during that time. Don't be tense, okay? Otherwise, you can miss things. The same things you are doing in your routine practice, okay? IV sedation can be given if the patient is like apprehensive, and then if he needs, then we can give them NTD where it is indicated. And remember, RH negative gestation age is more than 7 weeks. So surgical, you are always going to
Okay.
cover with anti-D. And now when you are induced medically, then again you have to do.
Yeah.
So MVA, there are certain complications like incomplete evacuation. Don't bother about these numbers. Perforation of the uterus, even with MVA, can be there, and damage to other structures, extremely rare. Then there are certain contraindications to the outpatient MVA. If your patient declines to have procedure under sedation, or she is like nulliparous and she is not cooperative. Sometimes nulliparous and they are motivated, they will accept this intervention. Then you have to see that what is their pain threshold. That if they have any complex medical
Okay.
problems, then they should be admitted. Complex medical problems like cyanotic congenital heart disease or
Send.
maybe bleeding disorders. And
Okay.
then you should remember that there are certain contraindications like the size of the mass should not, that CRL should be less than 25 millimeters, and then the size of the total
Mm.
pregnancy should not be more than five, contents should not be more than 5 centimeters. So just mention a couple of things. So they can be done, and you will need to do
Mm.
the tell them about the complications and TD. We have talked about that. That means sometimes we need to, in a very small number of patients, we need to repeat the procedure. Uterine perforation, intra-abdominal trauma, ongoing pregnancy, cervical
Mm.
damage, hemorrhage infection, intrauterine lesions. Then there are certain follow-ups, contraindications, like we said, that if the size of CRL is more than 25 or the size is more than 5 centimeter. Follow up the same. She will just come to the clinic, and or she can go to the GP or community midwife, and
Mm.
at that time you should not be offering any
Okay.
ultrasound or any stuff. Okay, that is the point.
Okay.
So in the exam this time, expect that they will give you some simple topic like the patient will be under 12 weeks, but first 4 to 12 weeks. Then you will
Mm-hmm.
see that you can offer. Even if the congenital anomaly is diagnosed before 24 weeks of pregnancy, even
Mm.
for termination of pregnancy. Like the patient didn't follow up. This is the first time he has come to a doctor, and
Mm.
lots of the baby with some abnormalities. Then you can offer
Mm.
the termination of pregnancy. So now, if he is more than 12 weeks, then again you have to see that patient is fit for the procedure, abortion
Mm.
is justified or not. So you don't have to, if you remember the clause, well and good. If you don't remember, don't mention that. Don't worry about that.
Okay.
That thing they
Okay.
have tested in the written exam. Okay? So
Mm-hmm.
then we say that again the same routine that you will offer medical termination of over 12 but under 24 weeks of pregnancy. Again with your
Okay.
prescription followed by which can be taken orally, followed by an interval of
Mm-hmm.
not less than 24 hours and not more than 48 hours. But usually on down, they will call the patient back at 36 hours. All routes can be used. And what we can do, we can give them 400 microgram buccal, vaginal, or sublingual administration 3 hourly. If this
Okay.
protocol fails to complete the medical termination, the protocol can be restarted after a minimum of 12-hour rest and preferably 24 hours later. So
Okay.
again, you will repeat mifepristone. Then,
Mm.
you will give this 400 micrograms 3 hourly
Mifepristone.
and maximum 5 doses. This is in the second
Okay.
round.
Mm.
Then, in the setting of a previous uterine scar, you should say you will take opinion of the consultant obstetrician.
Mm.
Mifepristone 200 mg orally, followed by an interval of not less than 24 hours and not more than 48 hours. We, the patient has a previous surgery, like cesarean section was done or myomectomy where the this uterine cavity was breached. So you will give her 200 microgram and you will give a rest period of 24 hours. Again, you can
Okay.
give 200 microgram misoprostol. So this is half the dosage. Right? Unscarred
Okay.
uterus, give 400. Scarred uterus, give 200 micrograms 4 hourly. Before we were giving
Okay.
3 hourly. Again, you can give 5 doses.
Mm.
And it can be increased to 4 hourly interval. Before we were giving at 3 hourly interval. And then it can be repeated after 24 hours with 6 hourly interval. So the duration will increase. That is the point. So if you remember this much, you are good to go. Don't have to worry. So if you are going to do this ERPC, you are offering surgical termination of pregnancy up to 14 weeks. Like patient is 13
Mm.
plus 6, you can do ERPC. At 14
Mm.
weeks, it will become dilatation and evacuation. So just
Mm.
pay attention to the gestational age. We can do that. Rest of the things are the same. And because still it is in the initial process, so many things will change, but rest of the things are going to be the same. Just you are going to follow all of this information has been taken from the NICE guideline on termination of pregnancy. So don't worry about anything. Okay. Any question? Any
Okay.
problem here?
Uh, so these values are different, Dr. Aisha. Like I have gone through them. This for termination is different dosage of misoprostol. For miscarriage, it's a different dosage of misoprostol.
Yeah.
Am I right?
Actually,
Yeah.
yeah. Actually, you don't have to mention the dose. Only you will say that
Mm-hmm.
in cases of the cases
Okay.
of this termination, just of
Mm-hmm.
this miscarriage of this 800 micrograms can be given. Okay, larger gestational ages, you will have to give multiple doses.
Okay.
Doses, they will not ask you like this, but just remember that in cases of
Mm-hmm.
scarred uterus, you will say that you are going to give a lesser dose of the
Okay.
this one. That is the point.
Okay. Okay. Fine.
Lesser dose of the substance. So I can see here Dr. Fariha. Assalamu alaikum, Dr. Fariha. How are
Assalamualaikum. How
you?
are you, Dr.
Walaikum
Aisha?
salam. I'm fine, thank you. How are you?
Yeah, fine, Alhamdulillah.
Okay, that's great. So long cases. I think we uploaded all of them, like maybe 10 or 14 long cases are on the web page. So Dr. Priya, your exam is tomorrow or on Saturday?
Saturday.
Okay, that's great. So you still have one day in ahead. That's good.
Yes.
For you people,
Mm.
short cases will not be difficult. Now this long case has become more important. Actually, it has always been very important. But the point is that now an examiner will be sitting there all the time. Okay? It can be a bit stressful, like they are watching you. So here, like here I've mentioned, this is the VTE case. All risk factors are here. So this document contains like 23, 24 pages. So, and this is on the web page. I hope that you are
Web,
able to
web
access
page
that
on
page.
the ARIS exam or
Yeah, on the Aries website. Okay, I will send the link today also. I will
oh,
send the link today also because I want you to go over this one because
Okay.
this is an important topic. Rather more than six, like 50% of your exam. So that is essential to go over this one.
So, Dr. Aisha, regarding termination, like in UK, they are offering termination at any stage if it is
Yeah,
affecting the life or the
yes.
mental health. So, in Ireland, it is only till 24 weeks.
You know, in UK, uh, in Ireland, up to 24 weeks. After that, if there is something like the patients, they will not come for follow-up. If it is diagnosed, you should say that they will not ask you about something for which they have not done any legislation. Okay.
Mm-hmm.
So, because the problem with this law is that Abortion Act, it was approved last year in April. Okay. So still their legislation is in the budding phase, and if you will go to the web page, the interim guidelines are there. These are not actual guidelines, interim guidelines, where
Yeah,
they are doing this stopgap arrangement. So don't bother yourself with the keys, with the terms that Abortion Act this and that. Don't have to do that. Okay? Just remember the management, and they're basically saying everything that we have mentioned in the NICE guidance on management of miscarriages. So the things we mentioned, I will also upload this recording. Same things, and I will upload this document also, so you should not have any problem. The same thing, same care. Basically, you know, you have to mention certain things. Identify the patient. Identification is very important. Take a good history. Were her periods regular? When was the first day of the last menstrual period? And what exactly she did? So how the pregnancy was dated, or is it her first visit? And then, you know, you will have to do this, review her cycles. What is the, you have to determine that she is less than 12 weeks. Okay. Was any scan done? So dating scan, but more number one thing is LMP. Regular cycles, irregular. Mention that point also. And after that you can proceed. So up to 24 weeks you can offer. If you need to offer something after 24 weeks, then you will say that you will make you will make a committee who will review the case, and they will give special consideration to the life of mother. Your job is to mention that why it is important for her to have termination at this stage. So you will have to address two things: maternal aspects of the care, that why we want to do this one, and fetal concerns also, because if this baby will have some serious handicap, then in case here we need to mention that this condition is incompatible with life. Because if they will give you someone which is very unlikely, if they will give you someone which is more than 24 weeks, that baby will have something very serious, like can have this Potter's anomaly, renal agenesis, and encephaly. So again, the same information. What is the point in continuing the pregnancy? The condition is not compatible with life, so after a while the baby is going to die. So better to take the baby out now, because at this gestational age, like if the baby is less than 28-30 weeks and encephalic transverse, still you can do this manipulation and the baby can be delivered vaginally. Okay? So take opinion, and then can make a committee and you can proceed. You know, take out this thing from your mind that this is that now you are in Ireland and this is not UK, because practices are essentially the same. The same. Um, I have seen, like, I cannot even say that there are five differences in their practices. Okay, so don't worry. And they will ask you straightforward questions. And whenever you are mentioning this management of this termination of pregnancy, confirmation of ID, confirmation of gestational age, and then does she have any risk factors, any medical history, any allergies, anything? And then is she confident that she would like to have this termination of pregnancy? Okay, that's fine. Document that. Tell her about the methods of available methods. No place for expectant management. You will have to offer medical or surgical. Tell them about the symptoms of medical, that it may take a bit longer, but she's she doesn't need any anesthesia and no risk of damage or any injury, and no risk of this bleeding or blood transfusion, or most likely. But we will give her painkillers. Okay, that is one thing. Surgical procedures, quick and short. She will be in control, but she may need anesthesia. Mostly it will be done under sedation if we are using manual vacuum aspiration. If she's not agreeing for that, that can be done under paracervical block. She's accepting, okay, fine. She's not accepting, then we will have to go for GA or gas mask. That is up to the discretion of the anesthetist. Then in that case, you can increase your marks, give antibiotics, give give these painkillers, then give them something for cervical priming. Okay, 3 to 4 hours before the procedure, you should press them. Then say a couple of things about the complications of surgical procedure. She can suffer, right? She can have like very, you don't have to remember that chance of uterine perforation 2 in 1,000. So if it is a discussion, then you can say that chances of laceration are there. What is the most common site of perforation? Anterior wall, fundus. Just a couple of things. Bleeding can be there. She may need blood transfusion. So if the role player is sitting there, then ask her that when need arises, will you accept blood transfusion or not? After that, NTD. Then tell them that products of conception will be sent for histological examination, histopathological examination. She doesn't want to have that, then ask her what will you like to, how you will like us to handle the remains of pregnancy. Then after that, painkiller, and she can go for follow-up to the GP, community midwife, and then we need to offer her contraception. She needs further information, offer her patient information leaflet. Always give early pregnancy assessment unit contact number. Remember, in each hospital in Ireland, each maternity service, it has early pregnancy assessment unit. It is mentioned in the RCPI guideline also. So put in contact with the sports group, with the sport group. Then see if the patient is likely to develop some psychological issues. Then make another appointment with her and see that you can manage her or you need to refer her to the psychiatry service. Document everything and you're going to be fine. Just treatment options, you already know about them, nothing different. Okay, so you should be relaxed and calm. So for the long case, I will resend you the link and try to go over that. But still, if you have any problem, then tell me. I will send you again. Don't worry about that. Okay, because this is important. You will be watched, and that is the most important part of your exam, because to fail or to pass, this decision is made on the basis of your handling of the patient, which is very unfair, because, and even if they bring anyone who has a very rare condition, just follow the same template of history taking. History taking in OB and history taking in gynae, both documents are available on your web page. So you actually today and tomorrow you should go over certain things. Cervical screening program, that is very important, because risk of cervical cancer is increasing, incidence is increasing, and some of the candidates they find it very complicating, so you need to revise that. Then instruments, because you will recognize the instrument even
But
if
we
it
don't know
is.
which guideline to revise cervical screening, because the cervical check is little different from the
Yeah,
cervical.
yes. So can you tell me about the differences between the two, if you like? Few
They are
differences, right?
following the Bethesda system, the cervical check.
Yeah.
Uh, they said that low grade squamous intraepithelial lesion and the high grade squamous intraepithelial lesion.
Yes. That
And
is.
the low grade they will do HPV, and
Yeah.
in the high grade they will, moderate and high grade they will direct do colposcopy.
Yeah. That
Oh,
is the point.
ASCUS is little different. ASCUS, they said that they will repeat after 12 months, and if after 12 months again they will repeat, and if it is negative, routine recall. If it becomes positive or if HPV positive, then colposcopy.
Yes. They will do the tri-age. Then what about the age of starting this all procedures?
On the cervical check, they have mentioned 25 to 60.
Yeah, that is what.
25 to
25 to
50 years.
44
Yeah.
they
49.
mentioned 3 year, and yeah, and from 45 to 65 year.
Yeah,
Right.
these are
It's
a few
25
differences.
to 49, 3 years, and from 50 to 65 is 5 years.
It's 5 years.
And 6 months prior, yeah, 6 months prior, that is 20, when she reaches 24 and a half year, you will get a postal thing
Send an email.
remembering you about your screening.
Yeah, you have to remind them. Rest of the things are going to be the same. Okay, don't worry about that. Cervical cancer is, last year there were many cases of litigation. So again, maybe they will like to ask you something about that. It is simple because the system is also very simple. But if you will go to their website, yeah, these are the points of cervical check. Basically, I will say that these are the differences, that they are stopping at 60 rather than at 65. But now they changed the interval. Until 2 years ago, they were saying that you should screen all patients every 3 years. That was one difference. Then nomenclature, they are using different systems. So they are following the American system. US also, they are following the Bethesda system because they find that this one is more practical. That is the point. Okay. So when will you say that the sample is inadequate? Cervical sample.
If they cannot look at the transformation zone, or they cannot make out the cells are normal or abnormal, then they say inadequate. Or if the sample is insufficient.
Yeah. Actually, it should contain cells, like you said, it should sample whole of this transformation zone, right? Whole
Mhm.
of this transformation zone should be, sampled. And if you don't find endocervical cells, then this sample will be inadequate. Then, if you find something, you will have send for colposcopy. And that's all you need to do. So, tell me about the vaccination for cervical cancer. HPV
Vaccination,
cancer,
yeah, yeah.
HPV vaccination. Yeah.
Yeah, HPV vaccination should be started at the age of 9 to 12 years, first dose. And we have the quadrivalent and bivalent. That is Gardiner is quadrivalent, which is 16, 18, 31, and 33. And the bivalent we have is Cervarix, which is 16 and 18. So it should be started at 9 to 12 years, and the first dose, and second dose should be given about 6 months later, the second dose. And if in case they have missed the second dose, this third dose, we can give it up to the age of 25. If I'm not wrong, I think
This Gardasil is against 6, 11, 16, and 18.
11, 16,
16,
18.
18, 6,
6,
6, 11,
6,
16,
11,
18. Yeah, yeah,
16, and
yeah,
18.
yeah, yeah.
6, 11, 18.
6 and 18. But
16 or
now there is a
16.
9, Gardasil 9. That contains, I think, this one,
Against,
30.
yeah,
Yeah,
against 9, you can say
9
that.
one.
That
Mhm,
now they are
mhm,
using a nonavalent. Okay.
mhm. And it will also helps against the what it will help against the vulval cervical cancer. Yeah, Praveen.
Just, just remember the main points. Okay. Don't have
Mm,
to go into the details. Okay. That is
okay.
one thing. Even for any OSCE, nobody expects you to know, tell them about 10 or 15 things about each thing. Just mention the main points and you're going to be good. Because in the check boxes, even in the RCOG, I have seen that they will give you one case, and you must have seen the examiner. That examiner is holding like a sheet of, this document containing 8 or 9 pages. Okay. One side is printed. So they will just continue ticking the boxes. So 2 minutes gap after once you finish your station. Why this gap is there? Because they will assess your performance. Okay. Okay. And you must have received your tickets, that you should know that on which station you are going to start your circuit. Okay, pay attention to that number because you should not miss like 30 seconds or any time. That is the point. So you both are taking your OSCE on Saturday, right?
This
Non-judgmental.
conference will now be recorded.
Yeah.
And first, we should see that she does not have any emergency like situation like fractures, or she's not bleeding. So we have to look at the injuries and give her comfort, any painkiller, or put dressings on the injuries. And then we have to ask her a brief history. And basically we have to tell her that if she want to take it further, then we have to involve the multi agencies like social services, police, and we have to ask her choice, like she will if she wants, then we will take the swabs and all and photographs with her permission. And then there are a few things like we have to discuss this again STIs and protection against them, then HIV protection, then we have to discuss emergency contraception and antibiotic cover if she has any injuries or if she has lacerations and she's bleeding. And then long-term contraception we have to discuss. And
Yeah. And then cover her for this Hep B vaccination.
yeah, hepatitis
And then,
B and
yeah,
hepatitis C screening.
and empiric treatment for emergency contraception should be given. And then you should give her, what else you should give her? HIV prophylaxis. So how you can post-exposure prophylaxis for
Prophylaxis.
Hep B and HIV infection. That's all you need to tell them. So then they can ask you that who is going to report to police.
I think patient herself has, we have to ask her that if she wants, then
Pay attention to the age of the patient. Okay.
age.
Why?
Okay.
Because if she's younger than 18, then we need to do that. Okay. So if she is more than 18, then she can go and refer. It's up to her. You will counsel her, but you will not prompt her. So then she can do. So uh, what will you do? Like you are a medical officer and you have seen that your patient has some issues, like he has been raped, you suspect that. So what will you like to do? So you will call the forensic expert. Okay, forensic officer should be called. If he's there, he or he is there, then they can help you with that. And if they are not there, then you will have to do. You will have to take all of these things. You will have to make the drawings. You will have to take the samples. And even if the patient doesn't want to report the case, in that case, you will say that we are keeping your samples so that if you feel the need, you feel like taking this again, then you can, reporting the case, then you can do that one. That is one point. So basically, you are going to touch on all of these things and give them empirical treatment for PID. So what would you like to give her?
Like we can give her doxycycline. We can give her like 14-day course of doxycycline and metronidazole, 100 milligram BID and metronidazole 500 milligram BID for 14 days.
Yeah, you need to give her all of these things.
Azithromycin.
And
Azithromycin 1 gram.
that's a
Yeah.
good addition. Azithromycin, we need to give azithromycin also because the patient will need all of these things. And what else you would like to see?
Pregnancy test if she misses a period. Yes, emergency contraception, antibiotics, then test of cure after for STD after 2 to 3 weeks, and 3 months for HIV and VTRL. Then screening for sexually transmitted diseases.
So HIV prophylaxis you will give for
4 weeks.
4 weeks. 4 weeks,
Yeah.
okay. Usually they will not ask you about the medicine, but what medicine should be given ideally to such patients?
Truvada and
You can give tenofovir.
tenofovir.
Efavirenz,
Yeah. Yeah.
tenofovir is given very commonly. So all of these things should be there.
Only tenofovir or with amtricitabine or only this one?
Even if you will give this simple tenofovir, even that is good. Okay?
That is.
And so if you are confused, you are stuck, then you should say that you will take opinion of the HIV physician also. Okay? Don't say deceive opinion of the virologist. Okay, you need to tell them categorically that we will call the
And sometimes it is written
physician.
that we have to offer her and we have to explain the side effects, and then she will choose that whether she wants or no. Or
It can have about 2-3 side effects, not all. Okay, it can cause lipodystrophy, can have abnormal liver test, just a couple of things. It should automatically come to your mind whenever you will talk about any drug. Just mention a couple of side effects. Okay. Doses, they don't expect you to know them. Tell them about that. But you need to ask her that is she allergic to any medicine? Because patient can have any allergic reactions. Patient may have like any history. Maybe she took this thing before and she developed some problem. That is the point. Basically, your this exam, like in the short cases, you are going to see just one role player. Then 1 or 1.5 station, they will carry some. They will display some instruments. Can ask you about lab results. They can ask you. They can show you certain X-rays, pictures, IUCDs, an instrument. Something simple will be there, but that will be in a bit rapid sequence. Okay. Or they can give you just a document like maternity dashboard. I think we did that one also. Labor ward prioritization code, audit report, that how you're going to review medical literature. So you know the steps of critical appraisal, audit, and then how you will assess protocol of some hospital, these things, and then they can ask you about some surgical procedure. Okay, so 1.5 days will be covered. 1.5 station will contain any of such things. So basically, at 4 stations, you're going to have this hardcore viva. Pay attention to the questions, what exactly they are asking you. And usually, they will be on common topics like diabetes, hypertension, because the patients who are more frequently coming to you, they'll be asking you about them. Instrumental delivery is very common. Then the complications of instrumental deliveries, any bleeding is always there. Can be heavy menstrual bleeding, can be amenorrhea. Okay, so bleeding disorders are always there. Patient with severe dysmenorrhea, patient having fibroids and requesting this abdominal hysterectomy. So viva questions and the typical questions will be there. They are not going to ask you about very rare conditions. Then sometimes once they gave a case on malpresentation, like they asked about occipito-posterior position. So many students, they said that they were very upset to see that. So you don't have to be upset. Occipito-posterior position. So what should be done? Or face presentation. What should be done in such cases?
Just we will this a prolonged rotation like OP. We will show the if the
In
dummy is
face
giving.
presentation, yeah, mento posterior should be delivered by C-section, whereas mento anterior can be delivered by vaginal. And we should also inform them that the fetal scalp blood or scalp electrodes will not be used, and vacuum will not be used. Forceps we
Yeah.
can use, and so an occipito-posterior, yes, they can have a 3/4 rotation deliver as occipito-anterior. Some can be persistent occipito-posterior, deliver as a face to pubis delivery, or some can get arrested like occipito to deep transverse arrest. In that condition, we will have to use a rotational forceps or a vacuum or manual rotation. And they take a prolonged labor and high chance of having a PPH third degree tears in this
Yeah.
instrumental
So
deliveries.
yeah. So you should say that in labor is by that the delivery is by the process of extension, and in both of these conditions, that
Mm-hmm.
OP, yes, it will have a large diameter, but in face presentation, the diameter is going to be just 9.5 centimeter.
Yeah,
But the problem is the position, the attitude, it is extended, right? So
yeah,
it will be hyperextended head, so the delivery will be difficult. So just do the things that you do in your routine practice. You will give some time to the patient. If it rotates, okay, fine. If it doesn't in occipito-posterior, it can go by 3/4. If it doesn't, then we will have to go for other options. Okay. And then duration is very important. Parity of the patient is very important. As they delivered before, descent and position, both things of the baby, they are going of the presenting part, they are going to decide your next action. So read the question very carefully. It will be not very hard or challenging, okay? It will be something simple. So if you are saying that you will wait or you will rotate, then you have to tell them, because in this position it is hyperextended, so it is difficult. So what about breech delivery? because RCPI has
breach.
its own guideline
Breach
on breech
usually
delivery.
like we should have like high hands-off technique.
Yeah. So
Any
when
case coming with
hmm
yeah,
if you have
breach. First thing
undiagnosed
you
breech,
should rule out any contraindications for a vaginal breech delivery, like the hyperextended head, baby weight more than 3.6 kg, or IUGR, non-reassuring fetal heart rate, or any congenital anomalies, or footling presentation. So these are the conditions where we won't allow for a vaginal breech delivery. So a quick ultrasound has to be done to rule out these things, and then explain to the patient the benefits and the risk that is involved in the vaginal breech delivery, as well as going in for a C-section. So vaginal breech delivery has a high risk of having a perinatal mortality, which is high compared to vaginal scephalic this. So and there is a increased risk difficulty in the aftercoming head, risk of dislocation or injury to the long bones, and so these are the complications that can be take place. There is a difficult like a third and fourth degree tear, risk of postpartum hemorrhage is also high. So these things, and but the benefits of vaginal breech delivery, yes, no any long-term morbidity or quick recovery. So so these things, and go for the C-section also. What are the benefits and what are the risks that is involved?
yeah. So
Yes.
anytime you will say that
And
you
if
are
it is,
going to,
yeah,
sorry,
we can
like,
even offer them an
yeah,
ECV. Yeah,
okay,
that if they are pre-labor, we can offer them in multiparous, in primary at 36 and multi at 37, after ruling out any contraindications for ECV.
yeah, that's true.
Mhm.
So whenever you will mention any surgical intervention or any other procedure, you need to tell the patient about all of these things, and then you will say that you will consider her wishes and you will include her in decision making. That's very important.
Okay. Okay.
So, if I ask you what are essential components of taking a valid consent, what will you like to tell me?
Essential components of a valid consent. Yeah. Components is first to identify the condition of the patient. Uh, then main thing is the time, place, and the person.
Yeah,
Um uh, who it is done and where it is done, see the patient's condition, any comorbidities, and whether alternatives have been discussed with the patient, and inform the patient what the procedure involved, what is the serious risk and the common risks.
And basically, we have to see that the patient is giving consent on her own. She understand what we are communicating to her.
Yeah,
She can
yeah.
communicate back to us, and there is no question or pressure on her. And she is giving at her own will. And then it is, like she has capacity. We have to establish that she has capacity, and then it is valid consent.
yeah, and that is very important that patient is giving it free of any
Free
pressure
of
or anything. Okay,
pressure.
so that is very important. Okay, and you should see her at least once without any other person, so to see that she is not being abused or anything. So these are important things. Okay, nothing else. So I don't foresee that you should be having any problems with such things. Actually, the examiners, they also know that very few students will be able to give them 100%, okay? 100% information on anything. So that's why you can say just simple things. So don't
Okay.
worry at
Yeah,
all.
yeah.
Just say the
Dr.
Dr. Aisha, I
Aisha,
have,
this one,
yeah.
okay, okay, ask Dr. Saida, no problem.
yeah.
You carry on. I just wanted
I
to
wanted to
ask you
ask
about the
about the premenstrual syndrome management, because I am confused in the psychological one, and the sometimes they are giving mood disorder, like more mood problem. How
Yeah,
to differentiate and how to offer her treatment.
yeah,
uh,
yeah.
premenstrual.
Yeah. Premenstrual syndrome. If your patient exhibits more and more signs of the psychological disturbance, like her routine is being disturbed,
Hmm.
then you will say that you will offer her this assessment and treatment. So start with the low dose SSRIs like citalopram in the luteal phase. Give for one cycle. If she improves, okay. If she doesn't, then in next one you will increase the dose and you will give it in the full cycle. Okay. If more mood disorder components of this, anxiety, stress, social inability, all of these things are there, she's under pressure, then you are going to give her these mood stabilizers, SSRIs.
But we can prescribe for them. We can
No,
ourselves.
no, we cannot. We will take
Then
opinion of the CBT, and we need to refer them for the psychiatrist. They are the one describing these drugs. We cannot just refer them.
and if she is coming first time and she does not have done any pain diary, then we have to tell her that first we have to establish the diagnosis,
Yes,
and
DSRS,
then we will. Okay.
DRSP, daily review of the symptoms
Yeah, they
in the
review.
prospectively. Okay, it should be done prospectively. So these are important points. Okay, the trick in the OSCE is that you should never say that, you don't assume. If they have given you clearly in the diagnosis that your patient is having a certain condition, then you will say that, okay, I will start from there, because you have to trust them. Okay, they have told you that it is she is having this problem and she is unable to carry out her daily routines. In that case, you should mention that what you will do, because they have given you the diagnosis. They have not given you the diagnosis, then we have to give her the diary, symptom diary, so that she will fill that. It should be completed by the patient prior to commencing treatment. You have to establish, okay? And then regarding these symptoms, so you will have just like, in cases of urogynecology, we are giving them this volume frequency chart, and the common name is urine diary for 3 days, right? Similarly, here we are giving them and asking them to record their symptoms for 2 months to establish the extent of the disease. So first line treatment: exercise, CPT, vitamin B6, a new generation pill. It can be given cyclically or continuously, and then continuous or luteal phase low dose SSRIs like citalopram, escitalopram. So you can give them both. Like your patient has more symptoms, so you can give her continuously. You will not say that, I will ask the patient that she will take it continuously or during the luteal phase, like day 15 to 28. More symptoms, give throughout the cycle, but the difference, low dose. She is benefiting, continue her on that. She's not, then you will say that you will give her estradiol patches plus micronized progesterone can be given in the luteal phase, day 17 to 28. Then orally or vaginally, and then you can give her a levonorgestrel, then higher dose SSRIs. Commonly, they will be given continuously on luteal phase. Previously, the dose was 10 mg, now 20 to 40 mg. If you remember, you can say. If you don't remember, then say low dose, high dose. Patient is benefiting, continue her on that management. If she's not, then go to the third line steps. GnRH analogs plus add back HRT, like continuous combined estrogen plus progesterone, like 50 to 100 microgram estradiol patches or 2 to 4 doses of estradiol gel. Don't have to mention it, okay? Or you can just give her tibolone. Nothing is working for her, go for the surgical treatment. Then when you will say this GnRH, so they will ask you that what are the benefits of this treatment. So her symptoms will improve. Drawbacks: she can develop postmenopausal syndromes.
More than
These
6
are
months.
just
Yeah.
simple things. Okay? She has low
Add-on therapy.
libido, and give add back therapy. Give tibolone. So then, if indicated, then we will think about the BMD measurement, and only you will stop the treatment if BMD has decreased significantly. That's all you need to mention. So let's go back to
Yeah,
the
Dr. Aisha, my question is quite silly. I know this
no
because
problem.
the problem is
First,
regarding the examination part. After you've come with the history and you've summarized the history to the examiner, Then you come on to the examination. You'll just tell the examiner, I would like to get her vitals checked, the pulse, the blood pressure, then look for anemia, pedal edema, calculate her BMI. You need to tell, or do you have to do it in front of the examiner? Like,
Yeah. You know, if I were you, what I would that now I need to see you for. She
okay.
will say, okay, what you want to do? You should say, just I want to look into your eyes. I want to do the general physical examination. I will not do any intimate examination because patient can be anxious, okay? Because you know it is not allowed in the exam. So just do the general physical examination. Then just take her pulse, okay? If BP of it is usually is not there, but if they keep this time, I don't know. I have no idea.
Okay.
Then, but still you don't have to. Okay?
Okay.
Ask her when did they check your vital signs? When did they take your temperature? When did they record some your blood pressure? So what did they say something about it? If nothing is there, then you should say, I like to do
Okay.
this because it is not no information has been given on this. You know, that's all. And then after
Okay.
that, the examiner you can tell the examiner that I need to do this examination. You know, these report grips they are always asking you because for most 90% cases are based on ops. Second patient. So you're going to
Okay.
you can do only this much. Okay? So the grips they will ask you to show them.
So, Dr. Aisha, when we finish the history, then we will do. Well, we will ask the patient.
The
We will
patient.
start examination, or no need to examine, or
Yeah. You should
examiner will tell.
yeah. So you should you will say that ma'am can I examine you? I'm just going to have a look at your have a general look. Then I like to take your pulse and I will not do any intimate examination. Is it okay with you? She will say yes. Okay. Address the patient respectfully in a normal tone. Go slowly, talk slowly, and then stand on the right side of the patient. Okay? That is important.
Okay. Okay. And
So
then
anything
after that, you start with the decontamination of your hands. Like if it's an
yeah.
obstetric case, then you go for
Yes.
the hand washing and empty her
Yeah.
bladder and then make her lie
Yeah.
down and go ahead
Yeah.
with the examination.
Yes.
Otherwise, first,
Yes.
yeah.
Very
I hope they
important.
don't expect us to check the BP pulse there.
Yeah. And in the last, yeah, that's very important patient safety point and WHO ethics also. And remember that RCPI has also mentioned on it in its handbook on examination format that not following the WHO hand hygiene scheme, it will result in an automatic fail on examination. This thing is very, very, very important. So if they will keep a sanitizer there, and if they don't, then you need to take the permission from the patient. Okay? Because you know they will say that you are travelers, you have not washed your hands, we are not sure about your hygiene. Oh, so why didn't you take the permission? Then don't touch your hair. You know, sometimes when we are upset or we are under stress, we will just keep this touching our hair, face, picking up at acne. Don't do that. Okay? Don't touch your face or any objects unnecessarily in the room of the patient. And if they, but you know, this is a long case, so most likely they will keep a sanitizer there because the patient will ask for it. That if some
Okay.
students are coming here, they need to wash their hands. Either a hair sink will be there, or you know, this sanitizer will be there. So it will take just hardly 30 minutes, seconds, or like 45 seconds. So you can do that. And if you need to wash, sometimes the basin is inside the room of the patient, then you can wash that. I like to do that. So please let me wash my hands and then I'll be back to you. So take a couple of tissue papers with you, tissue papers wipes with you. Okay. Okay.
This one,
And
Dr. Aisha, I did not receive any email showing that which when I will start the case. Like it is just a general email that 8 a.m. it will start. So case is not written here.
case number is not written here because
Yeah, maybe
in that
tomorrow
case,
they will send.
yeah, maybe no, I don't think so because they must have sent final emails. So don't worry. Then in the exam, before starting the exam, you should ask the examiner, okay? Because once they will sign you in, then you should ask her that what is my station number, okay? where I will start. This information is important because you should not start your circuit late at any station because it will result in wasting 1-2 minutes.
Dr. Zaida, you received any email like this?
No, I haven't received anything like that.
Just
Nothing
a
from
general
the
email, na?
RCPI.
Yeah, general
Yeah.
email.
One general email. Maybe one.
But when you
And
are registering, they will tell you because at that time also they confirm. Okay, don't worry. If they don't tell you, just ask them.
So
Dr.
after
Aisha,
the physical,
they are giving some HRT also on the station to recognize and to tell, or no, they are not
No,
giving.
no, they're not giving any
No
such things.
contraception, any contraception
Yeah,
on the
can be, can be.
can be.
Don't worry about that because all of these things which they can ask you. If you see here it is like instruments, and here I have kept like IUCDs, all possible things which I could think of. I have kept here for you. Like these even this urinary Foley's catheter, pessary. I hope that you should be able to see all of these stuff on the page.
A critical appraisal I never saw in the recall. It is coming. Critical appraisal of.
Once, yeah, audit very frequently they will ask. Okay,
Okay.
very frequently, like in each circuit, because they have different groups, but still they will ask. So we revise this stuff on critical appraisal, and I think appraisal of the medical literature is also there on the web page. Don't worry about that. So if you don't find that, let me know that.
Risk management station they ask.
Risk management can be there. Simple steps. Whatever you do in the routine practice, risk assessment committee, risk identification, risk management. We talked about all of these things. Don't worry, and I will again check that everything is there or not. We can show you just this picture. What are they doing? Amniocentesis. How they are doing under ultrasound guidance. Another person is doing ultrasound, and then we are aspirating the fluid around the baby. So stuff like that. Okay, then the procedures are also here. The incisions where they should be given. What are the benefits? What are the advantages, disadvantages? Then
This is on the website, Dr. Aisha.
sorry,
This is on the website.
that was because they are doing the ultrasound also. Can be done on any side wherever if you are comfortable you can do that. Okay. Why it is like this? Because maybe the patient have had this dominant left hand or something like that. This is the left hand, the right. Or maybe the picture has been taken this way. It can be the other way around also. So it depends that which hand is your dominant hand, and you have like helper with you or not. Then the oligohydramnios, they can show you a trace. Then how you will do this exam? What are they doing examination? What are these? These are Cusco speculum, and then all of these things, and then don't worry, it will not be that hard. So just stay focused, and you should not be having any problems. Because you have passed your written exam. In the OSCE, people fail by not following the rules, by delaying, and PID treatment, it should be on your fingertips, because these are important things. So patients can have many issues. Okay. So then the long case, so it will be something which is common, because no point in showing something which you cannot manage, like fourth stage of this endometrial cancer. You can't do much about that. So if they give you a malignancy, it should be in the second stage or in the first stage. Or cervical screening is very likely to be there. Miscarriages are going to be there. Anomaly can be there. Heavy menstrual bleeding is always there. In each circuit, either they will ask you about abdominal hysterectomy, its steps or instruments, indications, or vaginal hysterectomy. So these two procedures, you need to know them very well. Then third one is cesarean section. Don't go into the minor details. Miscarriage, since there are many guidelines, so definitely they will ask you something about that, and it will not be a gray area, it will be a clear cut station, and they will ask you about management. Then 10% chance that you will get a gynae case, and 90% chance that you will be getting an OB case, because otherwise also the maternity hospitals, they contain more obstetric patients. Okay, that's the point. And that would be a stable person, okay? Pre-op case can be there, post-op case can be there, can be anything. Don't be upset to see any patient. Just history taking is very important because this is your first introduction to the examiner. That how you are dealing with the patient. Go to the room, greet her, the patient, and then even before starting the history, you need to tell her that I'm Dr. Freeha. I'm one of the exam candidates. Can I ask you some questions? She will say yes. Then say that after taking a history, can I please examine you? I will not do any intimate examination, just a general examination and a couple of things. And say yes. You should say thank you. Then we can start. Identification is very important. Okay, you should start like this is a gynae case. Take name. How will you like me to address you? So, what is your date of birth? And then, so is she perimenopausal, postmenopausal, para, living, and how many live births? She hails from, where do you live? So have you attended, what do you do? So she will tell, what do you do for a living? So she will tell you about the occupation so you can have some idea about the education background. If she's a housewife, tell her that, did you attend high school? She will say yes. And any university, she will tell you family's monthly income. So, but you will have some idea about the socioeconomic status. That you will say that, are you happy? Can you meet your expenses? What is the marital status in a relationship? Do you live? Who lives with you? Because she's married or unmarried, not our headache. That who lives with you? Do you live alone? Chief complaint. She will do mostly. There can be a discharge, pruritus, bleeding, mass, or pain in abdomen, pelvis, and then mass is coming out of the vagina, and then that from where you were admitted. This is very important because maybe she has been referred from some hospital, or she's coming from the A&E department or from the outpatient department. History of presenting illness. That patient was apparently normal. How many days, months back? Then what happened? Elaborate the symptoms, duration in a chronological order. Etiology, cause, risk factors. Then did she have any complications? History of DM, hypertension, fever, UTI. Then history, if patient presents with discharge, like you should ask about the onset and duration, amount, is it scanty, moderate, excessive, type of discharge, consistency, if it is thin, thick, frothy, watery color, then is there any odor? Then this discharge is continuous or periodic, blood stained or not, any relation to the cycle, associated with pruritus and irritation. Then history in patient with bleeding per vaginum. Again, you need to ask her what is the pattern of the history, poly, oligo, metro, what is the menstrual history. Then pattern of the cycle, amount, quantity of flow associated with clots, pain, duration of bleeding, interval between two bleedings, continuous or intermittent, onset, postcoital bleed, intermenstrual bleeds, history of STIs, TB, any other disorders, COCPs or IUCD. If the patient has a mass or abdomen, onset, when she felt, is what it was sudden in onset or insidious, duration, size, growth rate, associated with pain, pressure symptoms like you can have an ovarian mass, ascites, any problem in the stomach, abdominal pain, distension, sense of bloating after meals and loss of appetite, weight loss, dull abdomen pain, dyspnea, nausea, vomiting, or history of pedal edema. If she has history of pain, actually you will say, tell me more that what do you feel about this bulge? How it has affected you. So she will tell you, and if she misses any point, you will ask her. Tell me about the pain. So she will tell you, but you should know that you should know about the pain, that it started suddenly or gradually, site, duration, nature, relation to cycle, radiation, aggravating and relieving factors associated with vomiting fever. Then if the patient has history of mass in the vagina, then you should ask that for how long she has been having this bulge, onset, and it is continuously present or it is present only at the time of straining. Activates by cough, by coughing, defecation, straining, exercise, lifting weight, and how does it relieve? Is it reducible or irreducible? Inconvenience is caused by the mass, but like patient is unable to walk, carrying daily activities. Like history of this prolapse, ask her that do you feel fullness in down below, and does anything come out of your organ, or does something hangs out? Reducible, can you reduce it or you can't? Do you have backache with it? Any symptoms, any abnormalities with the water work? So you should be mindful that there can be cystocele or polyuria, or the patient may need to strain to pass urine. Then you should ask about constipation, any problems, any problem with having sex, because this is one of the parameters of normal life. Then bowel and bladder history, then any history of urinary obstruction, any problems before, abdominal mass, fibroid, pressure symptoms, increased frequency, urine retention. Then about this, you should go for this menstrual history, age at menarche, attain menopause. If she's appropriate, that first you should ask about the first period or the last period. Cycles are regular, irregular, frequency, days of flow, 1 am associated with clot or not. When was the LMP? History of smears, are they up to date? Any abnormality detected before? What action was taken? Then if she is married mostly, then for how long in the same relation, any problems, any children, any form of contraception use, OB history or history of infertility, nulliparity, and the history of miscarriage, ectopic, age at the time of first, second, third conception, age of onset of sexual activity, and then did she breastfeed the babies, and were the babies vaccinated, and how they are doing now. Then OB history, like if he has like POP, then ask her that how many children, large fetus, number of deliveries, mode of delivery, any histories of miscarriage, any history of abnormal labor, interval spacing between pregnancies, like maybe multiparity with short interval is also a precipitation factor for POP. Then any other operative procedures like forceps, vacuum. In the past history, any surgery was done for prolapse before, because then you will have to do another procedure. Any history of removal of fibroids or any problem in the rectum. History of any surgical procedure. Past history of TB, PID, any disease. History of any other cancer. Then person history. History of allergies to any medication is very important. Then establish extent of allergy, that it is just a rash or prolonged problem of anaphylaxis. History of drug abuse, sleep, loss of appetite, weight loss, addiction, like alcohol. Do you smoke? Do you take alcohol? Ever thought of quitting? Tell them about the service, which is going to help. Diet, she's taking any high fat diet, fast foods, obesity, or high risk behavior like multiple sex partners, STDs, and or any history of discomfort during sex or pain during sex. Family history is very important. Any history of significance, any problem, anyone had any cancers, they develop any clots, so they will tell you. Then you will summarize the history and present to examiner. At this Mrs. So and so, how many years old, what is her status, and with where are live, how many births, came with this complaint, for how long, and what has been done. So what she did, how she is doing now, any history of medical problems, then any lesions, any other risk factors, differential diagnosis, and then in the tell the patient that can you is that correct, or you would like to add any point? He will tell you. That is all you need to know for history in the gynecological patient. So if we talk about history taking in the obstetric patient, again identification is very important. So name, age, address, occupation, education, what do you do for a living? So you will get some idea about the socioeconomic status. And do you live, where do you live? So this is important because we need to see that she can access medical facility or she can't. Gravidity, parity. Then OB history, what gravida, what para live births, miscarriages, period of gestation, when was the first day of the last menstrual period, did they tell you about your estimated date of delivery, where she was brought, and did she receive all immunizations? And she will say yes, no, scan, something was done, we will go to that later. Ask her that what has happened in the chronological order. Is it a referred case, from where she came, why she was infected, when, where, why, and what happened. Then history of present illness, like she will elaborate the symptoms, what happened, what were the complications, how is the baby doing, does she have any problems, medical problems. Then history of the present pregnancy. If she's in the first trimester, type of conception, spontaneous, artificial, planned, unplanned, how was pregnancy detected, how was pregnancy confirmed, urine or serum pregnancy test, and where was pregnancy confirmed. So where we can confirm pregnancy, like in the GP practice in the early pregnancy unit, and how many times she has been, is she regular with the antenatal visits, any unusual complaints like excessive vomiting, fever, rashes, and exposure to radiation, any vaginal bleeding, UTI discharge, any special drugs during pregnancy. Then in second trimester, ask about the number of antenatal visits, weight gain, what investigations were done. If she's not sure about the date, ask her when did you feel the first movements of the baby. Then if she has any risk factors, ask her about OGTT in the second trimester. Then because you can offer it with from 24 to 28 weeks. Any abnormal recording on blood pressure, symptoms of any gestation, hypertension, edema, bleeding. If she's in the third trimester, ask her that has did she receive regular care, proper, was antenatal follow-up proper, appropriate, any medical problems, how much weight she has gained, then any history of bleeding, or they can be bleeding, or there can be some discharge, there can be pain, any drugs, any labor pains, or any itching. Then menstrual history, again, menarche cycles, how were they regular, frequency, days of flow, volume, clot, intermenstrual bleed, lumpy, any abnormality, any use of COCPs. Then were your smears up to date, are your smears up to date, any abnormality detected before, what action was taken. Marital history, who you need, basically you need to, this is not essentially the marital history, that who lives with you, do you feel safe at home, do you feel good at home. Okay. Then previous OB history, how many conceptions, after how many years of marriage, type, history of any antepartum hemorrhage, preeclampsia, baby was small, any history of high sugar levels during pregnancy, how were her previous labors, induced or normal, spontaneous labor, any history of prolonged labor, type of delivery, was it SVD assisted, low second C-section, episiotomies, any history of blood transfusion, TPH, how was the baby, live or stillbirth, any weight abnormalities, any anomalies, any admission to the NICU. Breastfeeding was started at birth time and exclusively till, like in the first 6 months, there should be exclusive breastfeeds. Then how is the present health of the baby? How was the period after the birth? Was there any sepsis, any problem? If she received any catheter, like in case of cesarean, when was it removed? Was she fine? If she's ask her about her blood group, that is very important. They will not give you any idea. So do you know about your blood group? Okay, negative. So okay, we need to give you injections. We call them anti-D. Okay. Have you ever received them before? Then contraception used, spacing between children. If she has like a previous cesarean section, ask her it was an emergency section or elective. Did she have labor pains, blood transfusion, suture removal, catheter removal, any fever in the post-op period, any history of infections, how for how long baby was kept in NICU, when she was able to start breastfeeding, and how is the health of the baby. Any history of stillbirth, ask about the time or week of delivery, weight of baby, any history of labor pains, and why the stillbirth occurred, Was there prematurity, anomaly, IUGR, cord compression, preeclampsia, gestational DM, any miscarriage, what was the cause, the period of gestation, history of D&C, any procedures, then so any other terminations were done before, what was the indication, where did she have any complications, then past history, any general surgery, like maybe history on the surgery on gut, myomectomy, prolapse, epileptic, did she receive any blood transfusion, jaundice, TB, STDs, cardiac, diabetes, endocrine, thyroid disorder, any drug allergies? She says yes, then ask that person, how bad was it? Just you just had a rashes or you had some reaction. Then go to her personal history, on any medicines, taking any drugs, smoking, ever thought of quitting, does she need help, any history of psychological disorder, sleep, appetite, weight, bowel and bladder addictions, diet history before admission to the hospital, and now she's in the inpatient, so how she's doing. Then about family history, history of DM, hypertension, multiple pregnancy, anomaly, TB, bleeding disorders. And very important screening questions. How has been your mood in the last 4 weeks? Okay. Then second question, are you enjoying life as much as you were 4 weeks ago? So is there any change? So because these mental disorders are they're increasing, so very important to ask from all patients. Then how you will summarize the history. Mrs. So and so, this many years old, gravida para, with so many weeks of gestation. She came with this complaint, a referred case from somewhere like accident at A&E department or from the OPD. And what were the initial findings on examination? You need to ask the patient. Patient would have been prompted. She will tell you because you will do your own examination, but you will ask her also. That so when you present it to ER, so what did they find on examination? She should be able to tell you something. Okay, just mention that point, and you're going to be fine. So don't worry about that. So these are the points. Then what else? Take her consent before starting anything, before touching her, before doing anything. You need to take her consent. This is one thing. So basically, you should not omit any point in the history. Pay attention to all of these details. And before your exam, I would like you to go and revise all long cases. There are 10 or 14 cases on your web page. And these instruments, even if they show you something, you will get some idea that why we use that instrument. Describe that. That this is that what is this instrument? What is this called? How long it is? Does it have blades? It has handle. It has rings. It has a lock. It has this cutting edge, or this is for use for electropottery. You should be able to come up with something because and even if you are unable to identify that, you don't expect, then you should say that. So I honestly tell them that I know nothing about this instrument. So that is the point. Okay? So do you have any other question? Any problem?
Dr. Aisha, I cannot go on your website, so I don't know which link to follow.
Yeah,
I tried
I
to
will send.
open, but I cannot.
Don't worry, I will send this link to all of you because you should be able to revise everything here. And there are many stations also that we did in the when we were doing this course. I think in the end of October 20th to 22nd. Okay, you should be able to do that. Still, if you will have any problem, please let me know about that. You can email me. Okay, I'll be waiting and I'll be vigilant. Don't worry, I'll check it frequently. And if you want any guidance, on any specific issue, please let me know. Okay.
Thank you.
Yeah. So take care, and I wish you all the best. And you will do very well. You should not be worried. Stations are going to be simple, nothing complicated. If you forget something on the skills station, then just remember that one item will have just 1 or 1.5 mark. Don't be upset about that. Okay. So the appraisal of the medical literature, it is also available on the web page. So just go over that one. But you need to revise this OB and gynae history taking several times, because when you will do this long case, you will be observed by the examiner. Okay, so just do as you will do any case in your clinic or in your hospital. So take care. I wish you all the best. And before your exam, if there is anything which I can do for you, please let me know. Thank you very much. Okay.
Thank
Okay.
you.